First I would like to invite our keynote speaker, Dr. Rajini KC. She is a former professor and HOD of Government Medical College Thrissur and has more than 30 years of teaching experience in various medical colleges. At present, she is the director and chief consultant of Metro Eye Hospital, Iringalkuda. And she will be speaking on optic neuritis, the current scenario. Over to you, madam.
Okay. Good afternoon, everyone. At the outset, let me thank Dr. Rekha for giving me this opportunity. As you all know, in the recent past, optic neuritis, the trend or the scenario is changing because of the discovery of new antibodies, advent of new lab investigations, and the changing diagnostic criteria. In view of these changes, we need to review our management protocols as well. We see in the clinical practice all varieties of cases ranging the fundus picture ranging from the normal optic disc and right up to a frank neuroretinitis. So when you classify the optic neuritis, it is called typical when it follows the specific clinical pattern related to demyelinating diseases isolated or associated with multiple sclerosis. And when it is not typical, yes, it is atypical. So let us see the case which I came across in my clinical practice. This is a 20-year-old lady who presented with a sudden loss of vision in the right eye. She gave a history of viral fever in the recent past. So we asked for the pain on eye movement. She responded positively. And her vision was counting fingers at 3 meters in the right eye. And she showed a color vision defective also. And anterior segment showed an RAPD, grade 3. And fundus examination showed a normal fundus in both the eyes. But we did an MRI considering the RAPD, dyschromatopsia, and the defective vision. And it showed a hyperintensity of the optic nerve in both, and we saw the plaques in the MRI brain in the periventricular space as well. So this is a case of isolated demyelinating retrobulbar neuritis. So we managed this case with an ONTT protocol. A gradual improvement in the vision was noticed. The visual acuity improved to 612 and the color vision also improved and pupil also. And there was no recurrence in 2 years follow-up. So ONTT is the largest data source which give us information about the optic neuritis. So it is unilateral, subacute, painless loss of vision, painful loss of vision seen in young females usually, and pain on eye movements, and visual acuity usually is better than 20/200 at presentation. And whether you treat or not, the visual acuity gradually diminishes for next 2 weeks, then it becomes stabilized, then improves. So the visual outcome is the same in optic neuritis due to multiple sclerosis, whether you treat or not. Then why do you want to treat? We will come to that later. The visual prognosis in multiple sclerosis optic neuritis is excellent in around 72% of the patients and maintained visual acuity in both the eyes at 15 years of follow-up. So let us see this case, who is a 28-year-old lady who presented with a moderate defective vision in the left eye for 10 days duration. She didn't come on the first day. So no pain on eye movement. So no history of fever or trauma or neurological symptoms. The vision was diminished to counting fingers at 2 meter. Anterior segment was normal, no RAPD. The color vision was defective. And fundus showed a typical temporal pallor in both the eyes. So we went for an MRI in this patient. It showed again a hyperintensity of the optic nerve and typical plaques in the periventricular area. We call it Dawson's fingers. So definite pallor in both the eyes, suggesting recurrent episodes, may be subclinical in right eye, and MRI lesions in the optic nerve in the brain. The diagnosis is multiple sclerosis. So this is the revised criteria for multiple sclerosis. And the most important point to notice here is MRI lesions in the optic nerve in a patient presenting with optic neuritis have not been included in the criteria for diagnosis. So multiple sclerosis, the prevalence is more in the recent past. Maybe it is because the greater awareness about the disease or better documentation or a low threshold for MRI. 20% of all demyelinating disorders in India is neuromyelitic optica spectrum disorders, as we call it now, and 50% have aquaporin 4 or oligodendrocyte antibodies. 20% of multiple sclerosis patients have optic neuritis as their first episode of demyelination, and 50% of MS patients develop optic neuritis during the course of the disease. So when do you think of atypical neuritis, optic neuritis? When the vision is very low, maybe to no perception of light, maybe bilateral, optic disc or retinal hemorrhages, and severe optic disc swelling, macular exudates, absence of pain, presence of uveitis, and recurrent disease. So what is the etiology you think of when you have an atypical features of an atypical optic neuritis? So it could be infections or antibody-mediated neurological illnesses or systemic immune-mediated or lymphoproliferative related to hematological diseases. So we'll be emphasizing, highlighting more on the antibody-mediated neurological illnesses because this has gained an importance in the recent years. This is another case who is a 41-year-old previously healthy man presenting with defective vision in the left eye and history of defective vision, headache and the back pain in the ascending paresthesia. So we referred that patient for a second opinion to the neurological department also. The ocular examination showed a left optic neuritis. Surprisingly, we got a bitemporal hemianopia on field charting. And all cranial nerves were intact. Neck rigidity hyperesthesia below the T6 level also developed in meantime. Then MRI of the spine shows that T2 hyperintensities without enhancements in this patient. So 3 days later, the patient developed progressive weakness of the lower extremities also. So we provisionally diagnosed this patient as neuromyelitic optica spectrum disorders when we got the aquaporin 4 antibody test also positive. To my surprise, these antibodies, aquaporin 4 and MOG, are available in Thrissur, a small town as in Thrissur also. So this patient was treated with intravenous methylprednisolone and he improved. So is neuromyelitic optica is a distinct entity from MS. Earlier days we thought they are the same, two ends of one spectrum. No. So NMO antibody to aquaporin 4 was discovered in 2004 at the Mayo Clinic, and aquaporin 4 IgG antibody both a marker and pathogenic cause for NMO. So Aquaporin 4 water channels proteins are present in the astrogale food processes, and it is expressed in brain, spinal cord, and optic nerve. And when the antibodies are active against these water channels, these water channels are blocked and complement activation and astrocyte injury occurs, and thereby causing astrocyte death. This is the international consensus for diagnostic criteria of NMO spectrum disorders. We have core characteristics like bilateral or unilateral optic neuritis, longitudinal transverse acute myelitis, area prostrina syndrome, which presents with severe hiccup, acute brainstem syndrome, narcolepsy, Diane-Sylphic syndrome, and cerebral syndrome. So you should have at least one core characteristic plus an aquaporin 4 antibody positivity to diagnose, or you need two core characteristics if the antibody is negative. So just a recap, how does it differ from a multiple sclerosis? Age-wise, it is a middle-aged female, severe visual loss at the onset, poor recovery, 50% with 660 or worse, and less than one third of the patient presents with disc edema, involvement of the optic chiasma, where you get a bitemporal hemianopia as field defect, then involves more than 3 vertebral segments, and CSF shows pleocytosis. And another entity is MOG IgG optic neuritis. I don't have a case to show you for this. This optic neuritis and transverse myelitis are a common presentation in this, and 80% of the patient presenting with isolated optic neuritis, bilateral in 50% of the cases, and recurrent in 50%, and disc edema up to 86% at the onset, and can be severe with peripapillary hemorrhages. So this MOG antibody is a transmembrane protein found on the surface of the oligodendrocyte and myelin, and MOG antibodies are directed against the oligodendrocytes. And around 20% of the neuromyelitic optica spectrum disorder patients who were seronegative for aquaporin 4 IgG have been found to be positive for MOG antibody. So these are the MRI clues for MOG IgG optic neuritis, optic nerve sheath enhancement. Then enhancement may extend to the soft tissues in the 50% of the cases, and bilateral enhancement of long optic nerve segments, more than 50% of the length of the optic nerve is being shown hyperintensity. And this is a classical H sign, which is a radiological marker used to identify associated myelitis. So investigations we have discussed, neuroimaging we have discussed, we are going to have a session, a full talk on that. Then serology, CSF analysis, and OCT. So why neuroimaging? For diagnosing the various causes of optic neuritis to fulfill the diagnostic criteria for multiple sclerosis and NMO, and to prognosticate the disease. Serology is indicated in atypical optic neuritis. In the present scenario, you should go for serology in all cases of atypical optic neuritis to rule out infective causes, to identify various varieties of NMO-SD, and more sensitive than CSF for aquaporin 4 and MOG antibodies. The assay based on the cell line HEK293 is the most sensitive, 77%. CSF analysis is to rule out infections in general and tuberculosis in particular, and oligoclonal bands are seen in 90% of the MS patients, and pleocytosis and increased protein levels in aquaporin 4 optic neuritis and MOG optic neuritis. So how does OCT help you? OCT testing is considered a powerful biomarker of neuroregeneration and a promising outcome measure for neuroprotective trials in MS. And RNFL thinning may give an early indication of optic nerve damage. And the presence of microcystic macular edema in the inner nuclear layers of retina may be associated with poor vision. It is seen in more commonly with NMO spectrum disorders. So to management, maybe an acute episode, long-term management and for prevention of relapses and strategies of neuroregeneration. Acute episode, everyone knows the ONTT trials, ONTT protocol for, and this is for delayed onset of clinically definite multiple sclerosis and to prevent the recurrence at 2-year follow-up. MOG optic neuritis, significant visual recovery is usually seen with IV steroids, but you have to taper the steroids over 6 to 8 weeks. That is the difference. And limited role in NMO spectrum disorders. And plasmapheresis is effective when it is given as early, if the diagnosis is definite and is proven, you have to go for plasmapheresis. And these clinical trials, the results of all these trials showed a decrease in the relapse rate and delay in the conversion to clinically definite multiple sclerosis for at least 5 years. So long-term steroids, long-term management of multiple sclerosis, interferon beta 1 alpha is a very important role. And in neuromyelitic optica spectrum disorders, azathioprine is considered as the first line of therapy, and other options are mycophenolate and methotrexate. So this is to summarize how you diagnose and proceed, and this is to summarize how you treat these patients. Thank you for your patient listening. Thank you. Once again, thank you, Rekha, for the wonderful opportunity.
Thank you, Rajini Madam, for that very informative talk with case scenarios and illustrations.